Thank you. So again, the disclosures. Now, we know that when we talk about vascular calcification, this is really a pathology. And this is correlated to some risk factors generally connected to the age, to some metabolic disorders, and also some genetic disease. This is just to show you the cascade, then is the reason why we can have a heavy calcified lesion. And in this condition, we generally talk about ossification of the arteries because we have a completely alteration or modification of the enhancement of the vessel wall. Obviously, we have to think about the presence of two different types of vascular calcifications. There is the medial one that is correlated to the arterial stiffness, and this is, or the intimal that is more correlated to an atherosclerotic plaque that can favor the rupture or also the thrombosis. Obviously, what we are generally working on are the intimal calcification, and what we also know that in the majority of the cases it's very difficult to make a sort of diagnosis between the medial and the intimal calcification. This is just to show you the correlation between the two different types of calcification. You can see that generally we have more risk factors for the intima. That is also correlated to some inflammatory reaction. What is also important to remember that in many cases, especially in the FEMPOP region, there is a mix of both components, and this increases the complexity of the pathology. Regarding the risk factors, you can see that smoking and diabetes is the most common, but also hypertension, hypercholesterolemia are also important elements. Age, this is a very interesting scheme that show you that classification was observed in all arterial beds in 2/3 of patients older than 70 years old, and then we have calcium in one vascular bed in all the patients again over than 70 years old. So age is something very important. Well, how we can detect a calcification? Obviously, you can see we can use different diagnostic methods, but what is important that the majority of them are not able to make a difference between the medial and the intimal calcification. And we know that from a therapeutic point of view, this is very important. Just to give you an idea, angio, this is what we generally use in our cath lab, but you can see that this is the same patient, same level. You can see there is a big difference if you analyze the histological image with the angiographic one, because angiography generally underestimate the amount of calcium that is within the lesion. Very important, especially when you plan your strategy. We know also there is not a consistent calcium scoring system, and this is also a reason why we have a lot of problems to define what is a severe calcification versus a moderate one. There are several systems or the options. This is the compliant 360s based on 4 grades of classification: longitudinal, circumferential. We have the PARC system. This is the Peripheral Academic Research Consortium, but this scale do not account for intimal versus medial classification, and again 4 different groups. The PAC system is based on 5 different groups, all of them evaluated by angiography, unilateral, bilateral with a length greater or shorter than 5 centimeters. And finally, the system, the grading that we define our institution based on the use of angio, CT angio, and also IRIS that was used to confirm. And very important, we have 8 grades according to the diameter of the calcium distribution and also according to the length. If you analyze all those 4 systems, you can see, or methods, you can see that what is more important is that the bilateral or circumferential distribution is more, correlated to the severity of the calcium, greater or more than the length. So that it is where we focus more our attention when we evaluate a lesion and we evaluate a patient. So in conclusion, we can affirm that angiography underestimates calcium, and this is a reason because in many studies, the criteria of or exclusion criteria for calcium are very mild and vague. Bilateral circumferential classification are the most common marker of severity in all the different grading systems available. There is not a uniform consensus on which method must be or should be used to evaluate a device or a technology. And what we are looking forward, to a more validated peripheral scoring system that can apply in our daily activity. Thank you for your attention.